Great. Well, I'm going to be talking a little bit about enrolling my team's experiences with enrolling minorities with variable literacy into clinical trials. And the trials that I'm going to be talking about are trials of behavioral and educational interventions that we've implemented in clinical settings. So a little bit different from drug trials, but still similar concepts. See if I can figure out how to get this to. I don't know if I can. There we go. So I think, and one of the things I just wanted to say is, we've kind of heard it touched on a little bit in the beginning session, but that we know that there's a history of a well justified history of mistrust in the research enterprise on the part of diverse and particularly minority and African American populations here in the U.S. And so, in thinking about enrolling people into clinical trials, whether they be behavioral studies or investigational drugs or devices, understanding, the population and identifying with that population as much as possible when thinking about designing a trial and getting people into a trial, as well as the competencies related to health literacy, are really important. So, and I've heard these concepts all kind of melding together in the conversation so far, and so I think that really we're talking about a little bit more than just health literacy. When we're talking about enrolling people into trials, we're talking about how we engage people, how we relate to them as real people with real histories. I was just going to share very briefly our experience over 3 small trials that we've done on patients with kidney disease in Baltimore and in North Carolina. One was a study where we enrolled patients from dialysis units with kidney failure and from dialysis units in Baltimore. And there we were randomly assigning people to receiving their usual care or some culturally tailored educational interventions to improve their shared and informed decision-making about their kidney treatments. Another study was a study of urban African Americans with uncontrolled hypertension that were seen in primary care. And they received a community health worker intervention, blood pressure cuffs, and other educational interventions to help them improve their blood pressure self-management and blood pressure control. And a third study that we did in Durham, North Carolina was, again, looking at educational and behavioral interventions, as well as a financial support intervention to help to see whether that helped people consider pursuing kidney transplants. So diverse range of activities, but all these 3 studies focused in African Americans in urban or metropolitan regions on the East Coast. And I'm going to show you our numbers for recruitment and retention, which were reasonably successful. But I want to just say that one of the things that's been consistent with these 3 studies, the approaches that we've learned over the years, is that patient engagement or potential participant engagement before, during, and throughout studies is really critical, we found. Often when designing even our studies, the designs themselves, and then also the materials themselves, we've changed plans substantially, even from the original protocols, to accommodate what the potential participant population thinks is more appropriate. And that's a discussion in and of itself quite a bit, but it's just the idea that engagement starts before the study starts, even before you begin to develop these materials, and that helps inform the kinds of interactions you need to have with these populations over time. And then in terms of literacy, thinking about reading level and health literacy and cultural tailoring, I think, is another piece of this, quote, literacy piece, because an understanding is what we're really trying to build. We're trying to make sure that each side, the investigative team and the potential participant team, understand each other. And that's more than just language and words. That's also that's also culture. So I think thinking where people are coming from, what their environment are really important. And then just follow-up. So in our cases, using follow-up phone calls, in-person contacts when needed to really keep people engaged and help them understand the importance of their really being engaged in a trial from beginning to end. So I'm just showing some numbers here from these 3 studies. One study was 90 participants, one was 160 nearly, and one was 300. And the reason I put these numbers up are just that we were able to enroll, even though these are African American participants, which we typically say, oh, it's so difficult to enroll these people, they don't want to enroll in studies. We've had reasonable success with enrolling folks into our studies, upwards of 60% enrollment. And then also, fairly good retention. And so my point is that this can be done. There are approaches to use. I'm not saying that we've achieved perfection with it at all. And I was really interested with the newer materials that were presented in the last session and how to present informed consent and study protocols. I think those are very valuable. It's the lessons that I'm going to be taking away from here. But that I think it is possible to enroll diverse populations with variable literacy. This is actually information that we took from each of those 3 studies. The dialysis study on the left, the hypertension study in the middle, and the transplant study on the right. And what's here are just the literacy level, health literacy based on the realm short form, and then literacy based on the newest vital sign measure. And you can see that these populations really did have variable literacy with 50% often, or some up to 50% having limited or inadequate health literacy. So these are variable literacy populations, and they can be enrolled and retained in studies, and I think the methodology is really important. And I believe that trust and engagement is a part of that. This is not one of the newfangled consent forms, but I just wanted to share that I have gone through working with IRB quite a bit on how to tailor consent forms. And, the typical consent form, as was shown before, has such dense information, and we really have worked with our IRB to really cut out a lot of that language and simplify it so that we can communicate with our potential participants more clearly. And there's simply a lot more refinement that can be done. I do love the idea of video and iconography, if you can use that, and I'm definitely going to be taking that to the next level. But I've been really a little bit surprised at how often our IRBs are just not experienced or not accustomed to thinking about this, and that I've been fortunate to work with IRBs that have been willing to work with us on the tailoring of materials. The other thing I would say is just, let's see, again, I got to figure out how I advance before. What you do in your letter. So often, when we recruit participants too, we're recruiting them through their physicians or their providers, and the provider sends out a letter. We've really worked on with potential participants, what should that letter look like? And really, again, not just plain language, but the formatting of the language, bullets, shorter sentences, things that are more easy to understand, that make it more accessible, the information more accessible to potential participants. And then, of course, using tailored materials throughout the study. So that's really what I was prepared to kind of comment on based on our experiences. I think the engagement is important. I think the engagement is an entire discussion unto itself. How long that investigators have been engaged with the community, how trusted are they by a community, are they speaking the same language? This tailoring, not just being literate, not just focused on the language or the words itself, but the kinds of messaging, how straightforward it is, and how sensitive it is to the experiences of that community, and then the kinds of follow-up. And I'll just comment briefly on that, in that we have used postcards, letters, et cetera, but we found often that reaching out, calling people, even going to their homes to engage them and keep them engaged and understanding the importance of their involvement has been effective. The only other thing I'd pose, and maybe some of the other speakers could speak to, is I want to think about, I showed measures here on retention and enrollment, but are those the right metrics? Should we really be thinking about some other metrics that have to do with the experience of the participant and their satisfaction with their engagement with the trial itself, that goes above and beyond the receipt of the treatment or the intervention?
Great, thank you very much.